Good morning, everybody. Welcome again for the second day of the cardiology updates, the best of ESC, endorsed by the European Society of Cardiology. Dr. Ahmed. Today we have four important sessions. The first session is covering interesting cases in intervention cardiology. It's a competition between different cases, challenging cases. And the second session will cover the new hypertension guidelines, and we have the chairman of the ESC hypertension guidelines. And then we have the new clinical trials and the guidelines of peripheral arterial disease. بعد السيشن الأولاني هيبقى في الصلاة وبعد كده هنكمل إن شاء الله. So I'd like to invite the chairpersons. We have distinguished experts in intervention cardiology, Professor Magid Ramses, Professor Nireen Okasha, Professor Mustafa Muqarrab, Professor Hussam Hassan, Professor Ahmed Ahmed, and my dear friend, Professor Abdul Khan from Singapore. So the floor, you can start, Professor Nireen, Professor Hussam.
شكرا دكتور مجدي. We will start with the first case, Dr. Mustafa Amin. He's Assistant Lecturer of Cardiology in Armed Force.
صباح الخير. أنا مصطفى أمين، أنا مدرس مساعد أمراض القلب في كلية طب القوات المسلحة. النهارده إن شاء الله هنقدم أول كيس في الكومبيتيشن. المريض بتاعنا is a 60 years old male patient. He's non-hypertensive, smoker. He has no other history of medical importance. Can presented the ER with retrosternal chest pain that lasted 2 hours before presentation. High vital data of the patient was unremarkable, and his general and local examination also was unremarkable. The ECG showed ST segment elevation myocardial infarction in inferior leads, so the patient was immediately referred to the cath lab. Coronary angio showed that his left main is atherosclerotic, but there's no significant lesion. Also, his LCX is small, and it gives a sizable OM. The LAD is abruptly occluded after giving sizable diagonal. You can see that the LAD is totally occluded around not very long segment around 2022 with anti-grade flow. His RCA was totally occluded from the mid segment to distal, and his RV branch is giving retrograde flow to the LAD. So the decision was to undergo BCI to the culprit lesion, which was the totally occluded RCA. First, a regular wire, BT2 wire, was passed to the distal RCA, and multiple and balloon inflation with regular balloon. And after ballooning and multiple thrombus aspiration, the result was not that good. And this was the end result. We have TIMI around 2 to 3 flow in the distal RCA. We have good retrograde flow to the LAD. We have a very huge thrombus burden in the RCA. The vessel looks very diseased, and we can't appreciate here a very good landing zone if we are going to stent the vessel. So the dilemma here was to stent or to defer stenting. We decided to defer. We were afraid of no reflow in such a case, and also we could not appreciate a distal landing zone for the stent, so the patient was deferred. We went to a pill-out strategy. The patient was kept on tirofiban, and after 48 hours, this was his coronary angio. You can see that the caliber of the vessel can be well assessed, and we can see a distal landing zone in the BDA. So the patient received a stent in the distal RCA. It was about 75 تقريبا في 28 with a good end result. Next step was to do the CTO LAD or not. Actually, after 4 weeks, the patient was still symptomatic. His LV function was around 40 to 45. So we wanted to make sure that this myocardium is still viable or not. So the patient was referred to CMR unit to assess the viability of the LED. Actually, we can see here transmural enhancement. We can't tell if this is scar or not because it was only about 4 weeks, but we can see some endocardial enhancement in the LED territory. So we are now quite sure that the LED is still viable and is a good candidate for CTO intervention. So the intervention for the LED was planned. We calculated the J-score of the patient, which was not high. We have tapered stump for the LED is a proximal or distal, and the calcification was not that much. The bending angle of the patient was around was less than 45. The occlusion length was around 20 to 22 milli, and it was the first try to open the CTO. So this was around the score of J-score of the patient was 1. So this is considered intermediate difficulty. So we planned to open the LED. We started with the dual injection from a caster in the RCA and another guiding caster in the LED. We started contralateral injection. We can here appreciate that the length of the CTO segment is not long, and also we have a very good tapered end proximally in the LED. Also, the LED, especially the septal branches, the RCA gives retrograde to the LED through septal branches. A regular wire was passed to the LED. Over it, there was a microcaster. It was Caraval microcaster. And then it was changed to Felder XTA wire to select a good micro channel for the wire to go. Then the Felder XT kept to enter a septal branch. And so here we decided to escalate the wire to Gaia second wire. The Gaia second wire was a good option. It crossed the lesion. It could puncture the CTO segment, and it crossed the CTO segment distally. After that, we had the microcaster was advanced over the wire. Then we made sure that we are in a true lumen. The microcaster gave a good backflow, and there was also injection through the microcaster to confirm that we are in a true lumen in the distal LED. Then we used a regular wire. I think it was a BT2 wire. Then we started multiple ballooning for the proximal and distal LED until we could appreciate that we have now an LED, and now we are we're trying to fix the lesion of the proximal and the mid LED. We used IVAS. Actually, we used IVAS to assess the distal landing zone to make sure that we are standing on a healthy segment in the distal LED, and also to check the composition of the plaque if we need advanced intervention techniques in this patient. And we can see that here, that this was our landing zone. It was a little bit healthy. And here we can see a lesion in the mid LED. It was fibrotic lesion, and the proximal LED showed concentric calcification in the proximal LED. So we started to implant our stent. Actually, we calculated the size also distally. We can see that the distal can accommodate a stent of around 3, and the proximal can accommodate a stent for about 3.5. We started to fix the distally to proximally. We used a stent around 3 by 30. And then we used a proximal stent, which was 3.5 by 24. Finally, we have a fair result. We made overlap between the two stents. Surely, we appreciated that there some sort of oversizing distally. So we used another run of IVAS after trying to ballooning the stent with NEC balloon. We used the NEC balloons, 3.5 and 4 millimeter balloons. Then we used another run of IVAS. Actually, the IVAS showed that the stents were deployed distally and well co-opted over the wall, and also in the mid segment of the stented LAD, and also proximally it was well deployed and well co-opted over the wall of the LAD. Our take-home message in this case, it's a very challenging decision, especially in a critical patient in the cath lab was presenting with STEMI and with heavy thrombus burden. To defer or to stent is a very challenging decision. And IVAS is a key component, especially in patients who are undergoing complex PCI, is a bifurcation lesion or CTO segment, to guide the intervention, also to assess the complication and to make sure that the end result is well and good. Thank you.
شكرا يا دكتور مصطفى. بالتالي احكي بقى كيس عشان في اي كومنت على الحوار. انا بس بسالك على الاس بتاع الار سي اي في السكند سيشن كده، كان شكله
كنت ممكن ارجعه،
ما كانش موجود في الديagnostic، فده غالبا هيبقى سبازم.
Darsh, congratulations for this case. First, it's not the usual scenario to defer this lesion for glycoprotein to B3A. We have a fear of restenosis, reocclusion. You can use nitroglycerin or glycoprotein to B3A receptor on table and put a double wire in LED, wire in BDA, wire in posterolateral branch, and you can do direct stenting for right coronary to BDA or posterolateral branch. No fear for occlusion of side branch. Second, during intervention for CTO, we have a spasm in right coronary ostium. It's wise to put a wire in the donor artery for fear of dissection. If you have a tool, you can use it, of course. But angiographically, this lesion looks soft lesion, no much calcification. You did a good job, technically, step by step, to evaluate by IVAS and then upscalation of wire from soft to hard wires into soft wire again. It's not case, it's a good case for demo. Thanks for this presentation.
Thanks, Mustafa.
Actually, I agree with you for deferring the patient. Maybe I was going to defer him too because of the thrombus in the opened area of the right coronary and then the ratty appearance of the PDA. Maybe you had right because you didn't know the exact length that you want to stent at which. It was not a bad idea. And usually, even if it re-occluded, you will be able to open it. If you angioed him the next day and you find that the vessel is occluded, it will not be a difficult job to reopen it. So I agree. And of course, you are showing us that using the high-tech during intervention, definitely it helps. He did a cardiac MRI to detect the viability, which is the golden rule for detecting the viability. He used the double injection when he was doing the intervention of the LAD. I think he did a good job, and using the IVAS to estimate the exact size of the stent, I think it was good.
Thanks, Sadi.
Congratulations, but actually I agree with Dr. Mustafa that in primary PCI, I think it's better, especially when you have CTO LED and the right coronary is a valuable artery for him, that I will not leave the thrombus. You can try spiration device and do stent, but don't leave it. I think it's better as a policy in a primary that you leave the patient with STEMI 3, especially when the other vessels is CTO. But congratulations and everything is good.
Thanks.
Professor Galal.
شكرا يا مصطفى. يعني بس أنا ليا تعليق بسيط جدا. ده اسمه الميديسين اوف ريتش بيبل. أنا why I do MRI medicine of rich people. وبعدين العيان ليه أجيبه مرتين؟ أنا كنت عملت الرايت وعملت ال LAD إذا كان الإيكو ورى إن الانتيريور رول سليم وما زعجش العيان المصري. ما هو دايما أقول مع رصاصة واحدة ما جيبوش مرتين وعمل له MRI وعمل له IVAS. كل ده فلوس. ومصر ما في يعني يمكن انتوا عندكم اكويبمنت، انما انا ما نقدرش نافورد ده. انما يعني الحاله كويسه، بس انا كنت اعملها في سيشن واحد والعيان يروح وخلاص.
دكتور جلال, if he can afford, so when you can afford, you just do it. Thank you, Mustafa.
Nice case,
Dr. Ahmed?
Mustafa. Nice case. Good planning. The same as Dr. Devin tell. Good planning. I agree with you that defer in that time. The distal RCA is, I think, the sizing of and stenting in just condition not a good option. But the good planning in staging and selection of every equipment in its time, very, very good. Thank you. Thank you.
شكرا يا مصطفى. Past, present and future all in one case by Dr. Mohammed Hosni. طبعا the title is really attracting as the usual from Qasr Al-Aini. We are expecting to see something that unexpected.
Good morning, my dear professors. Thank you, Mr. Chairman. Thank you, Dr. Magdi, for giving me the chance to present my case in this elegant meeting. Thank you for all my colleagues. My case today is titled Past, Present, and the Future All in One Case. My case is a 71-year-old female patient. She's diabetic, hypertensive, status post-PCI to LED by biovascular scaffold, which is one of the bioresorbable stents absorbed in 2016. She was compliant to her medical treatment. In 2024, she presented again with new exertional angina, Canadian class 3, that was not relieved by medication. Her echo and labs were okay. This is the coronary angiography that was done in 2016. We can see clearly in this picture that we have proximal to mid-LED severe lesion. The LCX and the RCA were okay without significant lesions. We started to do BCI to the LED lesion. We started by the standard technique by doing pre-dilatation by 2.5 by 20, inserting the stent in the middle picture. The stent is not radio-opaque at all, 3 by 28, and post-dilatation by 3.5 by 15. And this, the picture on the left side, is while deploying the stent. It should be deployed very slowly. This is the full deployment of the stent, post-dilatation. And this was the result after the coronary after deploying our stent. This all was in 2016. The new coronary angiography in 2024, we went to angio the right coronary first. We can see that we have a severe lesion in the distal part of the right coronary. The left coronary system appear here. There was no significant lesion, especially at the site of the BVS. In the cranial views, there was a new lesion at the mid to distal LED, as in the middle picture. So we started to do BCI for the patient, and we adopted a strategy of drug-coated balloon for the right coronary artery. Being small in size, smallish in size, we started with good pre-dilatation, 2.5 by 20, and then essential drug-coated balloon, 2.25 by 38 millimeter, and this was the result after DCB. There was no complication with good expansion of the lesion. I was expecting that before doing the BCI for the coronary angiography for the patient, that the patient may develop the new lesion at the site of the BVS. I was enthusiastic to see what is happening in the site of the BVS, what the remodeling and the vascular changes that happened at this site. So we started or decided to do OCT assessment for the LED lesion and for the BVS site. This was the lesion. We can see that clearly we have a severe lesion. We used the OCT for vessel sizing and to see the characters of the plaque. There was no calcification. And we went to the site of the BVS. We can clearly a marvelous response that the vessel is okay, no complication, no residual parts of the previous stent. with only mild fibrotic plaque. This picture is not from our case. It was supposed an image in 2016. We didn't do the imaging before, but this is the live case image from our case. Then we went with the usual drug-eluting stent, Bromas Elite 2.75 by 20, and we post-dilated it, and we went with the OCT assessment of the distal LED lesion, and the stent was well opposed, well expanded, as you can see here, with no edge dissection, no complication. At that time, I started to think that what a marvelous response have been done by this BVS. It did the job 8 years ago without leaving any implants inside the coronary of the patient, without any complication. Actually, in this case, we used the 3 modalities of the patient: the BRS in the past, the DES in the present, and the DCB that was done in this case in 2024. All modalities were released actually nearly at the same time in the start of 2000, about 25 years ago. But the BRS was released or introduced in the clinical practice in 2015 as an absorb, with struggling course with the clinical outcome. The DCB started to show up at 2007, downgraded in the next 10 years, then resurged again, and it is now worldwide, it is an accepted method for intervention. The DES has the most successful long-term outcome in comparison to the other 2 measures, with a very stable course of innovation, first, second, third generation. In the next few slides, we'll go for comparison between the 3 strategies regarding pros and cons. Regarding pros, the concept of the BRS and DCB is leaving nothing behind. And this may address the cultural, religious, personal preferences that some of the patients do not prefer to leave metal inside their coronaries. The DES, as you all know, prevent vessel recoil. Regarding BRS and DCB have the advantage of unjailing side branches, unjacketing long segments, unlayering in instant restenosis. Both of them restore vascular compliance and remodeling. The BRS after its resorption, prevents the needs for very late adverse event and stent thrombus and restenosis. In DCB, good access, easy access to side branch simplify the procedure. It avoids the headache of stent protrusion, stent covering the ostium, and etc. And it's the best option in diffuse disease and in patients with high risk of bleeding. Avoid also chronic inflammation of polymers. However, the drug-eluting stent has more evidence, more familiarity. It provides definitive solution in dissection, left main intervention, and it's available all the time. Regarding the cons, DS and the BRS has all disadvantages of the stents. BRS, more target lesion failure and thrombosis in comparison to DS. Especially in BRS, they have struts. The struts are very thick, so it is more prone to stent thrombosis, had a limited expansion range, so may be exposed to friction and recoil, cannot be used in emergency situation. Regarding the DCB, as a cons, it's cannot be used in flow-limiting dissection, or if there is residual lumen stenosis less than 30%. It needs prolonged inflation time that might not be suitable in special situation like emergency cases. It may have an added cost if it does not do the job. And bioresorbable stent technology, the concept is there. Securing angioplasty result without leaving behind the permanent foreign body is highly attractive to both patient and physicians. As a general rule, any new device for BCI must be assessed against the therapeutic goal. If it improved survival, prevent myocardial infarction, sustain symptomatic improvement, avoid re-intervention with less complication, consumes fewer resources, so it is a good device. We have a lot of bioresorbable stent, but the most famous one is the Absorb and the magnesium scaffold. Regarding the trials that Absorb was used in it, we have 4 trials, Absorb 2, 3, China, and Japan. All of them have softish endpoints, smaller number of patients with non-inferiority design. So the results were not satisfactory. The investigators addressed why it's not satisfactory. They found that they were using it in smaller lesion, suboptimal implantation technique. They were not used in myocardial infarction patient in which they might be well suited. So they underwent with the Absorb 4 trial, but also it was not satisfactory result. They hardly reach the non-inferiority margin in the 1 year and the 5-year follow-up. So the idea is there, how to improve the BVS outcome in clinical practice and how to overcome the previous pitfalls of BVS. Firstly, by BSP, preparing the lesion, sizing the scaffold, post-dilatation. Senar struts as the fine resorb. It was used in the future trial with promising results. Abbott Vascular released a new one is Esprit with thickness less than 1 micron, and the newly released iron-based resorbable scaffold, which has a good result in porcine coronary arteries. My take-home message, BRS is a marvelous technology that deserves more research and improvement. Given the history of first-generation BRS, large-scale randomized trials are required before clinical community will adopt the next generation. The trials, if it is demonstrated comparable early and late outcome with superiority endpoints, a mass migration away from the permanent metallic cages to this more natural and holistic solution would occur. And finally, thin struts, good selection of the cases, standardized BSP technique, may plus minus OCT imaging guidance, may has set the stage for the resurgence of coronary BRS. And thank you for your attention.
Thank you for the marvelous presentation, but I think this is not the place for your presentation. This is a case presentation. You should stick to your case. It is good to give educative methods, but just as a hint. It was very good as a lecture in a separate place to have the voice. I don't know, you used the BVS on 2016, and the idea is to avoid putting metal in the vessel. You used a drug-coated balloon in the right coronary, though the right coronary is not a small vessel, it is a big vessel, it is more than 2.5. You could do an IVUS for it to assure this. And you used a drug-eluting balloon which was 2.5. And it was a proximal right coronary that you can just put your stent and you're not worrying about anything. This is one thing. As you used the drug-coated balloon, why didn't you use it in the LAD? The idea from the beginning, from the past, as you said, past, present, and future. In the past, you avoided putting a stent. Now, in 2024, you put a stent, a metal stent, in the med-LAD. The place, if you want to do any intervention later on or something, I can't understand the strategy behind what you did.
Regarding the right coronary, I think it's a smallish vessel, and either strategies, DCB or drug-eluting stent, can be used freely in this types of lesion. And there is no, the DCB is now coming as a substitute for the drug-eluting stent.
Totally agree. But why didn't you use this in the LAD?
Okay, I think the suitable size was not available at that stage.
As one heart center doesn't have the full range of the balloons,
sometimes in many labs, the full range may not be available all the time.
I doubt, but it is okay. And then, so that was the only reason that you didn't have the size or the length of the balloon you wanted to use.
I think, yes, this is
okay.
I have just one comment. In doing the drug-coating balloons for the RCA, used NC 2.5 and the drug-coating balloon was 2.25.
I increased it, more slightly
above. No, once you use 2.5 NC balloon, I think the drug-coating balloon should be 2.5.
Should be 1-to-1.
1-to-1. It should be 1-to-1. It will not be effective, whatever you are. Even there is 2 types of drug-coating balloon, NC and not NC. Both should be prepared by 1-to-1 size before.
I think minimal difference between them والنوت يعني big a big issue. بس your opinion.
Dr. Mohammed, congratulations. Okay. Okay, congratulations, Mohammed, for this
Thank you,
case.
Dr.
Totally, I agree with Dr. Nerine. You did a good job for right coronary, but you must use one-to-one DCV like NEC balloon. Second, you did a good job by OCT. You haven't much calcification. You can use another DCV for this mid-LED. Third, the BVC is there. It's default lesion for BVS. Well prepared, no calcification, no side branch, no jailing, no bifurcation. This is the default lesion for BVS. So it's good open till now.
Thank you so much. I'm not a specialist, but thanks a lot. We travel from the past to the future. It's like the case of in Egypt. If it was in present, what do you think? Maybe it is mainly for technical reasons, no? If it was the case presenting now, what should you do? Because maybe the size of the balloon, the expandable of the balloon is a stent boost to see exactly if you are optimal. And should you use systematically OCT, because all these things should help you to have the good result without using all these tools, no?
First of all, if the drug-coated balloon size 2.75 was present, I will use it. Either options are available and they are comparable to each other. Regarding the use of the OCT in the BVS, I honestly, it was an enthusiasm from me to see the result. It is for more research purposes. If it was not a case with BVS, I will not use OCT for this case, but for more educational purposes to see the vascular healing and remodeling that happened for this patient.
Okay, thank you, Dr. Mohammed. Any question from the floor? Okay, thank you, Dr. Mohammed. Now we can go to the third case with Professor Dr. Ahmed Kamel, Associate Professor of Cardiology, National Heart Institute.
Dr. Ahmed Kamel also is a Vice President of National Heart Institute.
Thank you, Dr. Magid, for this kind introduction. Good morning, dear professors. Thank you for the invitation. This is my case, a terrible nightmare. So the patient is an 80-year-old man, retired school teacher living in Tanta. He is non-diabetic and hypertensive, complaining of recurrent attacks of typical angina on mild effort. So he was referred for coronary angiography in a local hospital in Tanta. His angio showed severe diffuse atherosclerosis and calcification at the LAD with severe proximal and mid-segment stenosis. So the operator at that time advised for CABG versus PCI using rotational atherectomy. So the case was discussed in our heart team meeting, the weekly heart team meeting at the National Heart Institute with Dr. Magid, and the heart team opted for PCI with rotational atherectomy, as the patient was old and he has a very poor target vessels for CABG. So this is the PCI procedure. This is, as you can see, why this is a nightmare. Extensive calcification and stenosis in the LAD. This is an XB7 French 3.5, and this is, as you can see, as you can appreciate, severe calcification in the proximal mid up to the mid segment of the LAD with very poor targets at the distal LAD for a bypass graft. This is another projection. As you can see, severe calcification. I think you can see also the calcium in the right coronary. At the left-hand side of the video, you can see the calcium in the right coronary. So you can appreciate how severe the calcium is in this patient. So to decrease the expenses, we didn't use a microcatheter to exchange the rota wire. We had this 2O over-the-wire balloon just for exchange, and this is a workhorse wire, and then we left the over-the-wire balloon and we exchanged it for a rota wire, as you can see here, and we took the 1.5 burr, as you can see. Our target was to treat the LED only at this session and then see what will happen. The calcium in the right and left are obvious here. As you can see, the calcium in the RCA It looks very severe, and now we are doing the packing movement, many runs of atherectomy, and this is what happened. This is the control angio after atherectomy. We have lost everything. No LAD, no LCX. Severe chest pain, dissection of the left main. Then this is what happened. The patient went into cardiac arrest. So what did I do? Actually, I cut the very long rota wire and I used it to pass a stent in the left main while the patient was on CPR. My colleagues in the cath lab were doing compressions, and I was focusing to deploy the stent just to secure the left main. Still, they are doing compressions. The stent was deployed, but we don't have any flow distal to this stent. The CX is gone, the LAD is gone, everything is gone. The patient was crashing. Still, they are doing CPR. I did balloon dilatation just distal to the stent in the LAD, and this what I had. This is type 1 perforation. So I started with the dissection, the left main, and then I had this terrible perforation. So what should I do at this point? Just ballooning distal to the perforation. Now the wire is being pulled out. This is another problem. This is the rota wire. It is pulled out. So I took another workhorse wire and I advanced it to the LAD. Now I have some septals, some diagonals. The condition is better at that time. By this time, now I have some diagonals, some septals. The patient is not on CPR. He's ROSC. He's regained his blood supply and regained his cardiac contractility. So the wire went into the diagonal. So I wanted to pass another wire into the LAD. This is in the LAD. So now I am secured. I have an LAD wire and a diagonal wire. I have some diagonals are opened and some septals. So now I will just concentrate and think, what should I do? I'll just dilate the distal part of the LAD in order to see if I will have a flow in it or not. So I don't know if you can see, this is a 1.5 balloon with one knob in the bifurcation between the two wires, the LD and the diagonal wires. Still no flow distal, the distal LAD. So I try to open anything in the distal part of the LAD with the 2.5 balloon, just multiple dilatations, as you can appreciate here. Still nothing. So I decided to put a stent just to secure if there is any dissections or flaps that prevent the blood flow. So this was a 2.5, I think, by 28 millimeter stent. Now it looks better, but still we have some problems. This is the proximal part of the LAD dissection. I think this was a dissection flap from what happened before. Another stent, proximal, overlapping. This was 3.0. So now I think this looks much better. We have TIMI1 flow. If you can see, it's TIMI1 flow in the distal part of the LAD. We have some diagonals and some septals. As you can appreciate, I think, I don't know if you have seen this or not, I think we have another perforation at the site of the distal stent, and we used the balloon just to secure this perforation. I think it was sealed. So the patient was transferred to the CCU, mechanically ventilated with small dose of norepinephrine. I chose to insert an intra-aortic balloon pump just to secure his circulation. Then a few hours later, the patient was fully conscious and extubated. The next day, the patient developed ST segment elevation in the anterior leads. So I thought that we had a thrombus or something at the stent in the LAD, so we did a control angio. This is the RCA. As you can see, it's a big vessel. We have a severe stenosis before the bifurcation, but it's not our target now. This is another view of the RCA. We didn't touch it at the first procedure. And this is the LAD. As you can see, it looks much better. We have TIMI. We can say it's TIMI3 flow. The guiding is not deeply engaged. So this is a guiding catheter. Actually, I used the guiding catheter from the start. As I saw the ST segment elevation, I thought that this would be an acute or subacute stent thrombosis, so I used the guiding catheter, and this is what I had. The proximal LED and the left main are okay. We have regained the LCX, as you can see, the LCX and the big OM. This is a spider view. We have a good CX, a good OM, the LED, the proximal LED, the left main are okay. Distal LED looks fine. So the patient who was discharged to the CCU on medical treatment, 2 days later, he was discharged back home. So these are my take-home messages. Treating calcific coronary arteries is always a challenge to intervention cardiologists. Calcific lesions preparation before stenting is extremely important to allow stent expansion and prevent future stent failure. Many tools are used, as special balloons, cutting balloons, scoring balloons, non-compliant OPN balloons, atherectomy, whether rotational or orbital, IVL. So an expert interventionist should know which tool to use in which case. Whatever happened, left main dissection, cardiac arrest, LED perforation, please don't panic, and thank you.
احمد الحقيقه انت بتطلب طلب مش منطقي يا دون بانيك ده ما احنا بقينا بانيك واحنا قاعدين بنتفرج عليك
هو كلامي بيه
how to be don't how not to be panic يعني. Congratulations, a very tough case with a good behavior during the procedure and an excellent result.
Thank you.
Congratulations, Dr. Ahmed. Very nice management for a very tough complications and tough case. But I want to know what's your explanation for that? Is this the rota or the calcific beard that cause the occlusion of the left?
Actually, we used the 1.5 bear. I think this may be the rota bear or the guiding catheter. I don't know, but mainly I think this was the rota bear.
Okay. And do you think IVUS using to assess the left main before or after the rota may help you to prevent something like that, or it is
of course value? If it went smoothly I would have used the IVUS, but after cardiac arrest and perforation this was not suitable at that time.
Very nice presentation. Thank you, Dr.
Thank you.
Ahmed, as usual, you are a good man for dealing with complicated cases. I think Rotabir did a dissection in distal LED and dissection in left main.
Sure.
This is why LED abruptly occluded, and the patient arrested due to distal left main from fraction of bear. You used 2.5?
1.5.
1.5 bear. Okay, it's not too large, but it maybe cause this dissection in left main. Second, what is the cause of ST elevation next day?
Actually, I don't know. Simply, I don't know. Actually, I thought this was an acute stent or subacute stent thrombosis. It was 24 hours after the PCI. The patient was on an intra-aortic balloon pump and he was off ventilation, minimal dose of IV inotropes. I thought it was an acute or subacute stent thrombosis. I went first with a guiding catheter, not a diagnostic catheter. I thought I will do PCI or thrombus aspiration or something, but it was TIMI-3 flow and nothing was.
But your patient improved on ST elevation. Okay, thanks, Ahmed. Dr. Amirin.
Thank you.
If you have a comment.
I have to take a deep breath before even commenting on it. I didn't get it. What did you do for that contained perforation that you had at the distal left main and
just
the
balloon dilatation,
LED?
just sealing with a balloon, nothing.
Prolonged balloon inflation at this place? You didn't have the luxury actually for a prolonged balloon inflation because the patient is
actually he was
arrested and crashing and you don't...
We're doing CPR.
You were doing CPR. This is...
لا
كان contained. كان contained في مكان وكده
فجأة. Contained rupture, contained perforation.
Well, the unusual thing is that you had this contained hematoma. Usually, you continue seeing it till the end of the procedure, and even if you film the patient secondary, you will find this. Here, it's just immediately after two sets of CPR. It is not there, so this is unusual. The second thing, you were brave to put a stent in the segment that didn't have any flow, and you were not seeing anything. You just put a stent.
I had no choice. Patient was crashing.
There were no guarantee that it will help, but apparently it did.
No choice.
It did something. It did something. Yes.
Dr. Ahmed,
Dr. Ahmed wants to say a comment.
Thank you very much. And طبعا on behalf of psychocardiology, you are brave.
Thank you.
Have you felt any chest pain while yourself? Yeah, okay. The second thing, for the explanation of this perforation, Professor Galal Said is telling me now that it may be is intramyocardial contained hematoma. This is,
Yes, it is.
very good for the patient and for yourself. Thank you.
Dr. Ahmed, nice case as usual. The best here, as you tell, don't panic. You should be calm as you can. Decision also of stenting the distal vessel, I doubt that. I will not do like this in such situation. Do you do any medical management trying?
I'll just tell you why I stented the distal vessel. Because I didn't touch the distal part with the rota bear. So the distal part was there, and I didn't touch it with the rota bear. I thought this may be a thrombus or something migrated distally, because I didn't touch it with balloons or with.
It could be also. It could be also that from the bear passing, as you tell,
Actually,
it's 1.5.
The bear didn't exceed the mid segment of the LAD.
Ahmed, you used the Zions stent for left main?
I don't remember. مش عارف مش فاكر.
Mostly it was Zions.
اللي كانت موجودة يعني مش هفكر.
It's not a true dissection. Maybe hematoma, like Professor Galal said, or a very small, tiny perforation. Upon using NC for Zions stent, it may be protruded to 1 or 2 millimeter distally and covered the site of perforation.
Actually, I don't remember which stent I used. This was a very, tough situation. So I used 3.5 by the long 3.5 stent available. Don't remember the brand name.
Thank you.
As regards the RCA, you didn't do it.
ما فكرش طبعا.
That's enough, I think.
Okay.
It's okay. It's,
Well done, Ahmed.
Go to the next.
Thank you.
We have finished.
And we'll just show this case. It's an excellent case. I have seen it before. And it's presented by Professor Galal Said. And on behalf of Professor Galal, Professor Dr. Karim Al-Bakri will go through this an excellent case. It's a wonderful, challenging case in coronary intervention. And then we will go on the program. Yalla Karim.
Okay, this is a 69-year-old gentleman. He is known to have type 2 diabetes, hypertensive, and ex-smoker. He is known ischemic heart disease with history of PCI to LAD at 2014. He was symptom-free till last August when he started to complain of typical chest pain, Canadian class 3. His ECG doesn't have significant ischemic changes. Echo was normal with no regional wall motion abnormalities. So the patient underwent coronary angiography. As you can see, this is the LO caudal and the spider views. We do have a lesion at the distal end of the stent, in-stent restenosis of the old LAD stent. And as we can see, there is retrograde filling of the RCA. This is the lesion in the LAD in the LO cranial. The RCA has a CTO short segment in the proximal segment. So our plan was to do BCI for LAD and the RCA CTO. One stent in the LAD, it was a quick fix. Then we shifted to the RCA. This is the final results of the LAD. Then we shifted to the RCA as usual. Dual injection. We started with the filter XTA. However, it kept going to false lumen, so we changed it to a Gaia second that did the job. We reached it into the distal true lumen, ballooning, and then fixing the RCA with 2 long overlapping stents.
This is the final result, and this is non-compliant balloon, and this is the final results of the RCA. So, do you think anything is wrong in the last picture?
أيوة أقف هنا بقى كريم. We need to listen. Anybody wants to comment on the previous intervention? Anything looks not 100% perfect or anything to change?
I think this is just underfilling and negative remodeling.
Speak in the microphone, please.
That's okay. If you like to communicate.
I was just commenting to the rather large difference in diameter after the stent. It could be, dissection and intramural hematoma, but you already answered.
I think it's
negative remodeling. Yeah, it could be
due to underfilling.
Anything about LID?
No, the LAD is good.
Dr. Karim, is there any staining at the aortic root?
Staining.
Yeah, there is ostal.
There's not calcification. I guess it wasn't present at the
There's
start.
a contrast there. Yeah, it could be dissection at the ostal RCA.
Yes, that's what I mean.
I think it was present at the ostium at the beginning.
Sorry, excuse me, patient elective or?
No, this was elective.
Elective. What about RCA intervention from the start? It is doing any test to prove it is a ischemia related to RCA or LAD? The first question. Second question, there is oversize here apparently in RCA after the stenting. The patient develop any type of pain at the procedure or after procedure?
Okay. The patient doesn't have any pain after the procedure. Regarding the size of the stent, we use in CTO intervention, I think we tend to oversize more because the disease, the picture in the distal filling is much more different than the first pictures.
Yes.
I think it's all negative remodeling, and that we learned it from the studies about CTO, IVAS studies.
Yes.
And we will see next that the vessel is more than, the story will continue, but this was good.
Yes. Can you plan DCB after stenting and maybe need the BCI if need if there is any dissection?
Yes,
can
there is.
One of the option?
Yes.
In the RCA?
Yes, there is increasing interest in the use of DCB, especially in distal vessels, and in such cases in distal CTO lesions after opening the vessel, if you have distal small vessel, you can use DCB. There is growing interest in the use of DCB with good results.
Yeah.
Yes.
Yeah, let's continue detective work.
Okay.
Your distal PDA, periphery is missing, isn't it? Is it competitive flow due to collaterals, or is it embolization? Your PDA periphery is missing.
I think this is competitive flow from the
collaterals
of the left side.
And how did you size your proximal stent down to the middle portion of the RCA? Did you do IVUS, or did you control your results with the intercoronary imaging?
In this case, I did have the angio from 2014.
Okay.
So I used the size I saw by eye.
And what's the size of the stent? What's the size of the stent? Diameter proximal to the
2.75 and 3.5.
Why you select the ambulance from the start?
It's good support in CTO intervention. It's better to use better support, and the use of ambulance left is just routine in CTO cases.
Yes.
يلا كريم عشان الوقت.
Okay,
Final comment, if you want You have
No. I just wanted to ask, during the procedure, no ST elevation, no problems, no symptoms from the patient?
No. The patient was
so
very
uneventful.
good at the index procedure. He was symptom-free for 6 months. He presented to the ER with typical chest pain. During evaluation, he lost consciousness. ECG showed VTAC. He received 1 DC shock, restored the sinus rhythm. He was shocked, put on inotropes, and we transferred him to the cath lab. And this was his coronary angiography. This is the left system.
Just OCLOM.
Caudal and spider. The LED stents seems to be relatively good, with good distal flow, no problem in the LCX, and this was the picture in the right coronary.
Yes.
So it was oversized stent?
Maybe, or maybe it was the wire went into false lumens into true lumen, and the expansion of the subintimal space may cause this. Stent fractures may occur in RCE because this is the high mobile.
Can you raise your voice, please, Dr. Karim?
Maybe this is one of the theories. Maybe the stent was oversized. Maybe this is the mobile portion, and it is common to have a stent fracture in this size. Maybe the wire was in some way in false lumen, then entered something like a dissection re-entry.
Can I ask you something, please? I think this is an aneurysm, of course. Maybe the stent was implanted, maybe subintimal at this point,
Yes.
and with increasing pressure, this subintimal and an intramural hematoma caused this aneurysm. This comes by time when the blood flow is increased.
Yes, this was one of the theories. We can see here in the lateral view that the stents are, actually this is the lower, the distal stent. It's not at the overlapped segment. This is the distal stent in 2 different planes, and there is a big pseudoaneurysm with faint distal filling.
Karim, we all look at the pseudoaneurysm, and we don't look at the origin of the right coronary, which was completely normal before, and now we look, the origin is completely distorted. You can see the ostium of the right coronary and the proximal right coronary as well are not doing very well, not good, they don't look good. So not only that there is a stent fracture and there is a pseudoaneurysm, but apparently there is a problem with the intima of the whole artery from the previous intervention. Why this happened after 6 months, not after 3 months or after 2 months, I don't know. But there is something wrong all through the...
Okay, we'll talk about it, but there is a lot of theories. Okay.
Go on.
Okay. So what would you do in this situation? Any suggestions?
According to situation, if the patient is shocked now, can go to cover the stent at the pseudoaneurysm, or coiling is available for the situation. If the patient يعني stable or regain more or less stable, can do another session with patient. It's better as regards stability.
Okay.
So have you been thinking of rewiring and then putting a grafted stent at this point?
Yes.
And what is the situation? The patient, is the patient in the cath lab or in the emergency department or?
In the cath lab.
In cath lab. So that's the angio. So you should blow up the balloon in the RC and stop the.
He was not on intra-aortic balloon, but he was in a considerable dose of noradrenaline. And the patient hemodynamics during the procedure, he was systolic 100 to 110. So we choose to go for...
Was it pericardial effusion and hemodynamics?
No, there was no pericardial effusion. So we choose to go for intervention. We use the microcatheter, we first used a sine wire, then changed it to a sine black. There was difficulty to go to the distal true lumen. At first, I thought we have to go through the opening of the stent, but I think this is wrong because there was in two different planes. I started to manipulate in different directions. However, the wire kept looping inside the aneurysm, so I advanced the microcatheter more and did a loop with it and started to have more control on the wire, and the wire finally passes into the distal true lumen. The next step was implant or advancement of the graft stent. We have difficulty of advancing the graft stent because the wire was in two different planes, the artery proximal and distal part. So the graft stent didn't pass and the system was about to go out. So we used two techniques. At first, I used a guide liner supported by balloon, and I changed the wire into a Grand Slam wire to give me more support. Then we advanced two overlapping graft stent. This was papyrus, and we covered the RCA starting from its ostium to the distal part. And this was the final results.
Excellent.
I told you an excellent case. Fantastic. Karim وطبعا دكتور جلال قاعد this is an example of how challenging intervention can be sometimes.
Can I ask a question?
Yeah.
Congratulations, it was outstanding management of the complication. So did I understood you correctly? You never did post-stenting intracoronary imaging?
No.
No, okay. And do you think that stent was subintimally all the way down? False lumen, and then right?
This is one of the theories, but I don't believe in it. I believe this is one, this was one type of vasculitis. When I saw the patient, I think this was an infection. I have seen a case before presented in Argentina, a case like that, and the patient was having an infective endocarditis. However, this patient was stable, and his parameters of infection was not elevated, but it was a possibility. The second, I think it's maybe a vasculitis type of reaction to the stents.
To the drug, that was a drug-eluting stent, right?
Yes.
What
because
was it?
In 2014, the stent was a bare metal stent. And in the indexed procedure, we used science in the RCA, and in the LED, it was a Promus stent. So I think it may be an allergic reaction because the reaction was not just at the aneurysm and stent fracture, as the site of fracture, but it was throughout the whole stented segment. This was also a possibility.
And the theory that explains most of the findings, you have a problem also at the proximal RCA, some kind of pathology, aneurysm building there too. So what will be the theory that explains both proximal part of RCA, stent fracture, and the aneurysm?
Yes.
What's the theory?
Subintimal injury.
Yeah, from above all the way down.
Yes.
Yeah.
Dr. Karim, that was perfect. Then, just to conclude, the stent was implanted subintimal from the very start point of the RCA. And then, I guess, at the middle of the stent, the fracture came from like a balloon, like a pot, for instance. At this point, there was a stent fracture. And this stent fracture with the struts have caused intimal injury more, and that caused the aneurysm.
Yes.
I would just, that's what I concluded in the first instance when I asked you, you can have to put a graft stent. At the first time you rewired, I would say that a balloon, if you have put a balloon there at the point of fracture, And then when the balloon becomes inflated, and then you make an injection, if the aneurysm has disappeared, then you are probably in the same right position before putting the stent graft. That was my only
I did this with an
conclusion.
injection of a guideliner. I withdrew the guideliner slowly, then I did multiple projections.
Thank you very much.